capsulotomy openings have been studied, cruciate and circular. However, not many studies exist comparing the different capsulotomy techniques and their effect. Now, my aim is to find whether the size and shape of NDR capsulotomy has any effect over post-laser visual acuity, intraocular pressure and complications in pseudophakic patients with grade 4 pearl-type posterior capsular opacification. After IUC approval and due consent, a prospective observational study was conducted from February to July 22 in 100 eyes of 80 patients with grade 4 pearl-type PCO by a single surgeon under topical anesthesia. 1 month post lasers, the patient was divided into 4 groups based on the size and shape of the capsulotomy openings as follows. Group A, circular shape less than 3.5 mm opening. Group B, circular shape more than 3.5 mm opening. Group C, cruciate shape less than 3.5 mm opening. And Group D, cruciate shape more than 3.5 mm opening. The 4 groups were compared with respect to best corrected visual acuity, IOP, number of laser shots, energy used, and the rate of complications. Now, 100 eyes were divided into 4 groups of 25 eyes each. 60 patients had unilateral PCO and 20 had bilateral. 45 were males and 35 were females. Average age was between 44 to 84 years. And the average interval between cataract surgery and development of PCO was found to be around 26 to 72 months. The best corrected visual acuity 1 month pre and post laser was found to be comparable between all the 4 groups. There was an overall improvement in the vision post laser. However, there was no significant difference found between either of the groups. IOP 1 month and pre and post laser was found to be comparable. There was no significant increase in IOP in any of the groups, and none of our patients required long-term anti-glaucoma medications. However, the number of shots and the energy required was significantly lower in group A, which was circular less than 3.5 mm, when it was compared to the other groups, which was larger in size. When pairwise comparison was done, the laser shots were found to be significantly less in circular group, which was less than 3.5 mm. Overall, the smaller size capsulotomies required lesser energy. Similarly, the total energy requirement was also found to be significantly lower in grade 1. Rate of floaters was found to be highest in group D, which was cruciate shape more than 3.5 mm capsulotic group, and the smaller size groups had lower complaints of floaters. Now, previous studies have shown that a larger size capsulotomy helped in better posterior segment examination, however, is associated with complications and hyperopic shift. In our study, we did not find any significant difference in BCVA and IOP between the small and large capsulotomies. However, patients in the large capsulotomy groups required more energy and laser shots and had more floaters. Between the two shapes, studies showed that circular capsulotomy was associated with more floaters and macular edema on day 1. In contrast, other studies found that cruciate shape was associated with more intraocular light scattering. In our current study, we found no significant difference between either of the shapes with respect to best corrected visual acuity and intraocular pressure. Also, circular capsulotomy, which was less than 3.5 mm, required the least number of shots and energy when compared to cruciate capsulotomy, which was more than 3.5 mm. Also, more patients in the cruciate capsulotomy more than 3.5 mm group required more floaters. The limitations of our study was obviously small size sample size, a short period of follow-up, and fewer parameters, as a result of which larger sample size patients are required for better. In summary, both circular and cruciate-shaped capsulotomies were found to be comparable with respect to post-laser vision and IOP, but smaller capsulotomy size less than 3.5 mm required the least number of shots and energy, but with a similar visual outcome as compared to the larger size. Also, smaller size were associated with less floaters and fared better when compared to the larger capsulotomy. Thank you.
What was the correlation of this density of the PCO with the laser shots? Because that is not mentioned.
So, the density of PCO that we took was grade 4 PCO, which was significant in all the cases on only the pearl type PCO. Thank you, sir.
So next is Dr. Madhu Shekhar. Dr. Madhu Shekhar. Dr. Shekhar will be presenting on comparison of safety and efficacy of active Sentry and Ozil handpiece for Centurion vision system. Yes, please. So after this is Dr. Nilay Reddy. If you can get ready on this side, please. So you can start your presentation, sir. Timer ready hai us side mein? So timer de do. You can start your presentation. Mic udhar. Microphone udhar. Are 2 minutes, we have to leave the hall in time. You can come over here, sir.
नहीं आ रहा
No, this is not yours, no? Is this yours?
Yes, yes, sir.
Timer ready ho gaya?
You can start.
Yeah, start please.
Good afternoon, everyone. My topic of discussion is comparison of safety and efficacy of active Sentry and Ozil handpiece for Centurion vision system. None of the authors have financial interest to disclose. Traditional gravity-based fluid has been standard of treatment for decades, but anterior chamber tends to fluctuate after post-occlusion break surge response. Centurion vision system equipped with active fluidics designed to maintain target IOP to overcome the problem associated with variable infusion and aspiration rates. It compresses bag of BSS to overcome infusion line resistance and thus maintain maintain the anterior chamber at low IOP and stable chamber also. Active Sentry handpiece is equipped with fluidic pressure sensors. It senses changes in irrigation at the handpiece level and eliminating the delay in adjusting the fluidics. It also automatically detects patient's eye level. It is a prospective observational study. It is a prospective randomized comparative study in which 204 eyes of 204 patients were included. It was divided into two groups. 101 eyes underwent phacoemulsification using Ozil handpiece, and second group, 103 eyes, operated using active Sentry handpiece. All uncomplicated cases done under topical anesthesia were included in this study. All complex cases and combined cases operated under local anesthesia like subtenon, retrobulbar or peribulbar were excluded from this study. Complete preoperative evaluation was done for all patients. All surgeries were performed by 5 experienced surgeons of more than 1,000 phacoemulsification surgery. Patient eye level was set at -5 in Ozil handpiece, and it was automatically adjusted in active Sentry handpiece. All the parameters were almost same in both handpiece group, except significantly lower IOP was set for active Sentry handpiece. Parameters evaluated were patient's comfort level, where 0 was identified as no pain, 1 mild pain, 2 moderate pain, and 3 severe pain. Surgeons' comfort levels were subjectively assessed. 1 cannot proceed, 2 not comfortable, 3 comfortable, and 4 very comfortable. Other parameters were amount of fluid use, cumulative dissipated energy, number of times activation of active surge mitigation. So active surge mitigation works by partially venting the aspiration line, thereby reducing the vacuum demand from the anterior chamber. It detects occlusion break instantaneously and signals the quick valve technology to release fluid into aspiration tubing, just to prevent the surge. So ASM was activated in 51.5% of eye, of which 79% was in soft cataract and 20% in harder cataract. In 64% patient, it was activated for more than 3 times, and in 35% it was activated for less than 3 times. For comparison between the active Sentry and Ozil handpiece, moderate patient comfort level, moderate pain was encountered in around 30% of patient while operating in harder cataract using Ozil handpiece, whereas only 14% was patient complain of moderate pain with active Sentry handpiece. And surgeons were not comfortable in 30% of patient for harder cataract using active Sentry handpiece. But it was statistically insignificant. Coming to discussion, similar comfort level of patients were observed in more than 60% of patients. Surgeons were more comfortable using Ozil handpiece while emulsifying harder cataract, but active Sentry was a better surge protection under lower IOP, operating under lower IOP. Greater number of patients with harder cataract experienced pain in Ozil handpiece, no significant difference in CD levels between two groups. Limitation, we were unable to compare endothelial cell loss. Conclusion, to conclude, active Sentry technology was safer and equally efficacious as Ozil handpiece in Centurion vision system with added benefit of operating under lower IOP. This is my reference. Thank you.
So how this technology is different from the Ozil, the active Sentry?
Active Sentry, that handpiece is having that sensor, so it identifies decrease in IOP in patient's eye at the handpiece level only. So it reacts faster.
Okay, thank you.
Did you compare the epithelial thickness, endothelial thickness, and
no, we have not compared. It was limitation, sir.
Okay.
Thanks.
Any more questions for doctor? No, thank you. Thank you very
thank
much.
you, sir.
So next presenter is Dr. Nilay Reddy Korpal. You can start your presentation. Just give me 1 second. After that, I would like to invite Dr. Jai Gopal, sir. Please come over here so that you are ready with your presentation. And timer ready at 5 minutes, please. Timer at 5 minutes. Yeah, you can start your presentation now.
Yeah.
Screen. Yeah. Timer start कर दीजिए. Thank you.
Yeah. Good afternoon. I'll be presenting on comparison of clinical outcomes of Icryl Toric and Alcon Toric IOLs in a real-world setting. I have no financial interest. Coming to the introduction, nearly 40% of cataractous patients have been shown to have more than one diopter of corneal astigmatism. There are multiple treatment options for corneal astigmatism, such as spectacles or contact lenses, PRK or LASIK, limbal relaxing incisions, or phakic or pseudophakic IOLs. Pseudophakic IOLs have shown to be effective, safe, and predictable. Their drawbacks include incorrect evaluation, marking errors, and post-op instability of the IOL. Our current study is to determine the efficacy of an Indian-produced toric IOL, Icryl, and versus that of an international toric IOL, Acrisof. This table shows us the differences between the characteristics. The important ones are both toric IOLs use a hydrophobic acrylic material, and both have a 360-degree square edge design. The haptic designs are different, and their cylinder power ranges from 1 diopter to 6 diopters with 0.5 steps. But only clinically they correct up to 4 diopters of power. Coming to the methodology, it was set in a single center, single surgeon in South India. The inclusion criteria were all patients who underwent toric IOL implantation, Acrisof or Icryl. The exclusion criteria was any patient with less than 1 month of follow-up, any history of corneal, retinal, optic nerve, or amblyopia, irregular corneal astigmatism, previous corneal procedures, or any intra-op or post-op complications not related to the IOL design. Coming to the IOL formula, SRKT formula was used. The target refraction was a myopic shift of up to 0.5 diopters, and surgeon-induced astigmatism was 0.5 diopters based on his previous surgeries. Online calculators for Alcon and Icryl were respectively used. Coming to surgical procedure, marking pen and bubble marker were used in a straight-head gaze to prevent cyclotorsion. All patients routinely received a peribulbar anesthesia block, a 2.58 mm temporal incision, 5.5 mm rhexis, and hydroimplantation was used as retained OVD is a cause for post-op instability, and routine post-op care was given. This is the pre-op characteristics of both the groups. Age was shown to be statistically insignificant, and the refractive astigmatism for the Alcon group was shown to be 2 diopters pre-op and 1.7 diopters in the Icryl group, which was statistically significant. All these characteristics were calculated on a Lenstar 900. Coming to the 1 month post-op values, the UCVA was, the uncorrected visual acuity was similar between both the patients. It's given in logMAR here. It's 6.9 in both the groups. The post-op BCVA, best corrected visual acuity, was nearly 6.6 in both eyes. It's statistically significant here, but clinically it's nearly 6.6 in both the groups. The corneal astigmatism showed a significant reduction in both the groups with 0.5 diopters residual in Alcon and 0.36 diopters residual in Icryl. It was statistically insignificant. This charts now show the reduction in the pre-op versus the post-op corneal astigmatism. And this chart shows the pre-op BCVA versus the post-op UCVA from around 618 to 624 in the pre-op versus to 6.9 in the post-op. The post-op UCVA to the BCVA is now shown here. This chart shows the post-op UCVA in Snellen's charting. It shows that the majority of patients had 6.6 or 6.9 vision, and only a few percentage had 6.12 or worse vision. Coming to the limitations of our study, it was a retrospective study with a short follow-up of only 1 month. No IOL rotation stability evaluation was done at 1 month. There was no vector analysis, contrast sensitivity was not assessed, and there was no subjective questionnaire analysis done at the end of the post. Coming to the conclusion, both the Toric IOLs have shown equally comparable alternatives. Icryl Toric IOL is a customized low to high astigmatism correction, has shown similar effective functional and anatomical outcomes to the international ones. They also come at a lower cost, that is approximately a third of the international Toric IOL cost. So it's shown to have a good cost-effective alternative for less affordable patients who cannot afford the higher priced one. Thank you.
Doctor, did you find any difference of the marks? Because in the imported one, there are 3 dots that are placed peripherally. And in that case of the Indian group, there is a single line which are placed more centrally. So in the final alignment, what is your opinion if the pupil comes down? Did you get any advantage in?
The operating surgeon felt that there was both were similar in the alignment and the post-op effect. He did not have a problem.
Thank you.
Thank you, sir.
So next presenter is Dr. Jayagopal Agarwal. He has 2 talks. So this one is on artificial intelligence-based IOL power calculation.
Yes.
And the next presenter is Dr. Varti Kashyap. If you can get ready here. Is the timer set at 5 minutes on that side? Ready? No, this one is Dr. Jayagopal Agarwal. उसके बाद Dr. Kashyap is ready on that side. So this one is artificial intelligence one.
First one. Should I start with the timer has already started.
No, timer is not started.
Yes. Respected chairperson, my topic is new trend of artificial intelligence based IOL power calculation is superior to the regression formula. No financial interest. The purpose of the study is to compare the accuracy and widely used IOL power calculation formula, including the artificial intelligence based formula. These are namely Hill RBF, LADA Super, and Kane formula. Rest are the regressions formula. When we upload the data of a patient, artificial intelligence-based formula finds a difficult pattern in apparently random cloud of data points already created by large number of cases that is based on the pattern recognition of artificial intelligence. This is purely data-driven and it is free from the limitation of expected lens position and free from the limitation inherent to the standard formula. We have come across very frequently the deep learning in this artificial intelligence algorithm. Here all the data are input in the input layer, and after the many hidden layers, after its processing and self-validation, we get the very correct output data. The preoperative investigation was done by IOL master, and the patients are distributed in the groups of axial length. For group 1 is axial length more than 24.5. Group 2 is between the 21.5 and the 24.5, and the group 3 is less than 21.5. 1 month post-operative results by the same profession and same autograph instruments were done for the best corrective visual acuity, post-operative actual dioptric power, and the number of dioptric error. 267 patients are is included in this study. This is the data collected from my studies, and the calculation is done by the statistical SPSS software. Mean were shown as the standard deviation, refractive mean numerical error, mean absolute error, and of the IOL formulas at different axial length groups are calculated and compared. Refractory error of the absolute value by percentage of each formula is calculated at 0.25, 0.51, and 2 diopters. Mean absolute error is used as an indicator for the IOL formula prediction error. A small standard deviation of the mean absolute error shows the accuracy of the prediction is very good. This is demographic data of my study. As is shown in this slide, the mean numerical error is very less in the heel RBF and the ladder super. So it is better than the other formulas. Come to the mean absolute error. Here again, heel RBF and ladder super gives the better prediction. This slide shows the sensitivity of the formula prediction at different powers, that is 0.525, 0.51, and 2 diopters. Here again, the artificial intelligence based formula gives the minimum post-operative error with more eyes within 0.5 and 1 diopter of spherical equivalent. The same thing is shown in this slide in our data. For extreme eyes, artificial intelligence based formula is better than the other formula. For the long eyes, mean arithmetic error is smallest for the artificial intelligence formula. For the short eye also, the artificial intelligence based formula again predicts the more eye within the 0.5 diopter, that is 26%. For the toric IOL calculation, with the artificial intelligence based formula is for the spherical part, and the Barrett toric calculator for the cylinder part. It gives a very good result, but the post-elastic calculation, no artificial intelligence formula is till now. For the issue astigmatism is compared by the centroid residual astigmatism prediction error. Here again, if artificial intelligence formula along with the Barrett toric calculator gives the minimum centroid error with the with and without WT and R and the ATR. So it is very good for the calculation if you use the artificial based formula with the Barrett toric calculator. Here the same thing is shown in the double angle plot graph. Here the red circle shows the minimum error. Here again the artificial based formula with the Barrett is very good. So to conclude, the advantage of artificial based formula is single answer for any IOL calculation query. It incorporates the sweet spots of many existing formula into the single formula and is totally data-driven artificial intelligence-based pattern recognition without estimation of expected lens position. So our artificial intelligence formula is continuously evolving, thus becoming more and more accurate, and accuracy is 90%. So artificial intelligence formula being the game changer is a grandmaster of biometry. Thank you for your kind attention.
So what additional parameters they are considering these AI-based IOL calculating formulas?
No, there is no additional parameters.
No additional.
It is already we have the just like other things. We just go for the all data and we upload it. Actually, already the lakhs of data are in the clouds. It matches only. And after matching, it comes to the very accurate calculation. Especially only the spherical part, but for the toric part, we can take the help of the Barrett toric calculator.
So they have data regarding the short axial length, the longer axial length, or the normal axial length eyes.
The lakhs of data are there, and it is gradually evolving. So if I use that artificial intelligence cloud data, then my calculation also upload and that data.
So any difference with Indian eyes?
No, no,
Okay.
it is not.
Okay, thank you.
Dr. Gopal, is there any source of error? What are the source of error in AI formula? Because you have been using the same data input from the.
It is almost negligible. It is almost negligible.
But you
It
are
is
acquiring the data
99%
from the same, from where you come bring your data for input in all?
What?
Data input from where? You calculate the astigmatism, IOL power.
Just we upload that. There are Hill RBF and LEDA Super. They have interface with the, all data we should entry with the IOL Master 700. That's what we do. And we get the very correct answer immediately. Even if the long eye and short eye.
Okay, online. No, calculate, but you are inputting. Input data is the same machine you are acquiring IOL Master from the. If your data is wrong, then your results will always be
That
wrong.
is different thing.
That is
That is different thing. If my calculation, if data is wrong, then it will be wrong.
आओ भाई लड़का इधर हेल्प करना बुलाओ उसको डॉक्टर सुगतो अरे खोलोगे ना इसमें कौन सा खुलना होगा कहाँ खुलना है खुलवाओ जल्दी से हाँ। बड़ा करो अरे इसको बड़ा करो ना इसको बड़ा करो
With us. So next presenter is Dr. Vartik Kashyap. In the meantime, may I call upon Dr. Pranay Kumar to the stage, please,
अरे इसको
to get ready for his presentation.
फुल स्क्रीन
So it is full screen here, ma'am.
okay there I have to be like that hello
You know what is coming next. That's the advantage of using this. So you just click and
okay
yeah, full screen is.
so good afternoon everyone. So my topic is clinical outcome of bilateral monofocal plus IOL IC-BOO with intended emetropia, group 1 non-monovision group with monofocal plus IOL with intended micromonovision in non-dominant eye, that is group 2 monovision. No financial disclosure. Monofocal plus IOLs can give good distance but not very good range of intermediate and near vision. With the arising need for better intermediate vision with least dysphotopsia, there is always a need felt for non-refractive extended depth of focus IOL without photic phenomenon. Additionally, IC-BOO has a modified aspheric anterior surface of the optic. It creates a continuous power profile, aims at improving vision for intermediate tasks compared with the standard monofocal and extends the depth of focus. It is based on refractive technology without diffractive rims and without zones. The purpose of this study is to compare clinical outcome of bilateral monofocal plus IOL IC-BOO with intended emetropia, that is group 1 non-monovision group, with monofocal plus IOL with intended micromonovision in non-dominant eye, group 2 monovision group. The outcome measures were uncorrected and corrected distance, intermediate and near visual acuity, contrast sensitivity, binocular defocus curve, spectacle independence, and photic phenomenon. This is a prospective non-randomized comparative study, single surgeon, tertiary eye care hospital. The group 1 is non-monovision group. Group 2 is monovision group. Both the group have 40 eyes, 20 patients. The first group has bilateral monofocal plus IOL with intended emetropia, IC-BOO. And second group has bilateral monofocal plus IOL with intended micromonovision group, micromonovision in non-dominant eye, IC-BOO only. So inclusion criteria is age 50 to 75, corneal astigmatism less than 0.75, endothelial cell count more than 2000, IOL implanted 20 to 23.5 range. In the back, the exclusion criteria are previous ocular trauma, irregular astigmatism, corneal dystrophy, history of glaucoma, intraocular inflammation, macular disease, or retinopathy, neuroophthalmic disease, intra and postoperative complications. The binocular uncorrected distance visual acuity and corrected distance visual acuity are better in group 1, that is a non-monovision, but comparable with group 2, that is the monovision group. The intermediate visual acuity, both uncorrected and distance corrected at 66 cm, is significantly better in group monovision, group 2. The uncorrected and corrected near visual acuity at 40 cm shows significantly better vision in monovision group, that is the group 2. The contrast sensitivity is comparable in both the groups. It is measured by modular transfer function measured on the eye trace. The binocular defocus curve was significantly better in monovision group at 1.5 to 2 and 2.5 versions. This is the graph. The post-operative reading speed at 66 centimeter and at up close were significantly more in group 2. The patients not at all bothered by starburst, halos and glares were comparable between group 1 and group 2 at 6 months. The proportion of patients having spectacle independence at intermediate distance 66 centimeter and near 40 centimeter were significantly more in monovision group 2 in bright light as well as in the dim light. What this study adds is that the bright light and dim light intermediate visual acuity at 66 centimeter is significantly better in monovision group 2 monofocal plus IOL with intended micro monovision in non-dominant eye, thus facilitating intermediate tasks significantly like computer work, reading labels in the shop, cards or board games, crafts, playing music. Near activity is significantly better in monovision group 2 in bright and dim light. The photic phenomenon, nighttime activities and night driving were comparable in both the groups. Thank you.
Dr. Kashyap, one point. What is the relevance of monovision nowadays with the availability of
because
continuous
this is a
range
cheaper
of
lens,
vision?
na? This is a cheaper lens.
Only the
Cheaper lens, and if you see, there are a lot of modalities, like people are doing mix and match nowadays with trifocal in one, people have compared trifocal both eyes, then trifocal in one eye and multifocal in another eye. But then there is a problem of this photic phenomenon with them. This does not have a photic phenomenon, it's a very cheap lens. We have gone for a VVT, but VVT is very costly.
Thank you. Next is
Yeah. So next presenter is Dr. Pranay Kumar. And at the same time, Dr. Jayagopal Agarwal, if you can come over to this side, please, for your next presentation.
Good afternoon, everyone. My case is a rare case of lightning-induced unilateral total cataract presenting within 24 hours. No financial interest involved. A 12-year-old boy presented with sudden loss of vision in the right eye a day after sustaining a lightning strike. Examination revealed superficial burns to his left arm, left and right lumbar region, and a dense cataract in the right eye. There was no evidence of other ocular manifestations, and his left eye was normal. Lightning-induced cataract progressed very rapidly and can also involve the posterior segment. Keeping in mind the implications of lightning on visual outcome, we report a case of an isolated unilateral pediatric cataract due to lightning. Lightning-induced cataracts are rare, and much more rare is people escaping death in such situations. So there is a high probability of such cases going unreported. The chances of being struck by lightning in a year is about 1 per 9,60,000. The resultant manifestation of lightning injury is due to either mechanical disruption or due to localized inflammation, which is secondary to high energy transfer in the form of heat or electric current. Cataract is the commonest ocular manifestation of a lightning strike. Injuries due to lightning has been reported in various literature such as keratitis or uveitis in anterior segment, retinal detachment, papillitis, and macular hole formation in the posterior segment. Coming to our case, a 12-year-old male student from Hazaribagh presented to the IUPD with chief complaints of diminution of vision in right eye since 1 day. According to present illness, according to the patient, he was apparently well 1 day back and was grazing cattle in an open field. It was at this point of time a lightning thunderstorm struck nearby him around 20 meters away and he went unconscious. Patient's father further said that they took him at a local clinic for primary treatment, and from there he was referred to our hospital. After the patient regained consciousness, he started complaining of diminution of vision from right eye. There was no prior history of any serious illness, poor vision, ocular trauma, or red eye. The patient had a normal term at birth at term, thoroughly immunized with proper developmental milestones. Personal, dietary, family, drug, and other systemic history were insignificant. On general examination, the boy was conscious and well oriented to time, place, and person. Vitals were stable, and findings of systemic examination were within normal limits. Local examination revealed a superficial burn wound on the medial side of the left arm and a superficial burn wound on the lateral side of the left and right lumbar region. These are the classical filigree burns that was seen in that patient. Coming to ocular examination, the best corrected visual acuity of the right eye was 6/60 and the left eye was 6/6. The extraocular muscles, eyelid, eyebrow, eyelashes, conjunctiva, cornea, anterior chamber, and iris were within normal limits in both the eyes. Pupil was round, regular, and reactive in both the eyes. IOP Goldman measured IOP was 17 and 50 mm of Hg respectively. The lens of the right eye was cataractous while the left eye was transparent. On post-dilation, the slit line examination showed a dense cortical cataract in the right eye, and the fundus could not be evaluated due to opaque media. The disc was just visible. B-scan and optical coherence tomography also revealed no abnormality. The patient was informed about the status of cataract that has occurred after sustaining lightning. The patient was advised for cataract surgery of right eye with IOL implantation and was counseled for the risk of amblyopia. However, patient was lost in further follow-up. This is a photo showing the dense cortical cataract in the right eye and the fundus of the right eye. Lightning-related injuries are more common in developing countries. Lightning has been known to cause cataract for almost 300 years. Unfortunately, there has been no conclusive studies on the incidence of cataract amongst lightning victims. It is rare for a child to survive lightning and rarer to develop an isolated unilateral cataract. Cataract development has been recognized to occur immediately, but more commonly has a latent period of 1 to 2 years. The pathogenesis of cataract following lightning has been attributed to either decreased permeability of the capsule or due to concussion due to excessive contraction of ciliary muscle, or due to scar tissue formation with hyaloid deposition in anterior capsule leading to disturbed lens nutrition. These cataracts generally progress to maturity quickly, and so it is common that many such cases present as total cataract. Thank you.
Thank you, Doctor.
Thank you.
Okay, so Dr. Jayadasan, will be the next presentation. This side way. Can I call upon Dr.
नहीं है आपके इसमें. Where should I start?
Yeah, you can start your presentation.
Yes. Respected Chairperson, my topic is IOL power calculation after myopy classic or PRK. We have the comparative study between AIOCMTC calculator and EVO calculator version 2. There is no financial interest. The purpose of this study is to get the correct IOL power after myopy classic or PRK and to compare the different power obtained from the AIOCMTC calculator, including the Bilateral formula and the EVO calculator version 2. Number of patient is 19 with the previous classic for myopia and the subsequent cataract surgery. Maximum data regarding the previous refractive surgery were taken from the patients. Retrospective chart review was done for all patients. Here these three situations can arise. First, pre-LASIK keratometry and the refractive data obtained, but this option is no longer available on the AIOCMTC calculator, so we are not considering in this study. Second is surgically induced manifest refractive changes, that is difference between the pre-LASIK and post-LASIK refractive power and the current anterior corneal power measurement value. In such there are 5 patients, and where there is no history data, then here it is for 14 patients. After thorough examination of the patient, we got the corneal topography, IOL master reading and the OCT readings. All the data are entered in the AIOCMTC post-refractive IOL calculator. We get the 8 formulas results including the average, masket, modified masket, SAMAS, Haig's L, Barrett True Care A, OCT based and the True K with no history and average. For the 2 initial cases, I have used EVO calculator with version 2 as it is easy to handle. Result from the different formulas of AIOCMTC calculator are compared. This is the interface of the AIOCMTC calculator and EVO calculator. I have used this. The inclusion criteria, there is no complication after the cataract surgery. And it is the data obtained from my patient, and after that we calculate the IOL power of AIOCMTC calculator and EVO calculator I have shown in the slides. The prediction error calculated are the IOL prediction error, mean arithmetic refractive prediction error, mean absolute refractive prediction error, variance of in mean arithmetic refractive prediction error, and percentage I within the certain refractive error, that is within 0.5 and 1 diopter. What should be the ideal IOL formula? Ideal formula should have smallest mean refractive prediction error, smallest variance in that error, and the highest percentage of I within 0.5 diopter or refractive prediction error. This is a demographic chart we see in my study. IOL prediction error is the lowest between Barrett True K and Barrett True K no history, so it is better than other formulas. When we go for the criteria, the first criteria is refractive prediction error. Here again, the Barrett 2K and the Barrett 2K no history has the minimum prediction error. It is same thing. It is a modified band Altman plot. The readings are very close to the red line, shows the better result. So here again, the Barrett 2K and the Barrett 2K no history is better than the EVO formula. The same thing in box plot graph. I'm not going in detail. After analysis of the first criteria of the post-refractive prediction error, among all formulas, Barrett 2K gives a significant low mean absolute prediction error similar to the average value. According to our finding, EVO calculator can lead to large and significant refractive prediction error in eyes within the with large axial length, and even large error with the concomitant steep pre-elastic keratometric values. The second criteria is variance. Here again, the Barrett 2K and the Barrett 2K history gives the smallest variance. Now, third criteria is the refractive prediction error within 0.5 and 1 diopter. Here again, the Barrett 2K and the Barrett 2K history gives the maximum percentage of eye within 2.5 and 1 diopter. So, Barrett 2K formula gives the maximum accuracy with all three criteria, that is small mean refractive prediction error, smallest variation in that error, and highest percentage of eye within 0.5 of refractive prediction error. So, Barrett 2K provides the more accurate results, and EVO calculated version 2 slightly falls short of the above criteria. Thank you for your kind attention.
Thank you, sir.
Thank you. So next presenter is Dr. Rajendra Prasad, and after that, Dr. Pardhi Todi, please. You can get ready here. Sir, you can start your presentation.
Good afternoon. The title of my paper is High Dissect, New Surgical Technique in the Management of Complex Posterior Polar Cataract. We do not have any financial interest in the subject matter of this presentation. Friends, you know that posterior polar cataract is a surgical challenge due to its associated high incidence of intraoperative posterior capsular disruption. The routine phacoforces or any attempt to detach the cataractous plaque may lead to complete pre-extraction, disruption of the posterior capsule, and the incidence has been reported from 36 to 40% by most of the leading ophthalmologists. There are several techniques which have been described: slow motion phaco, step-by-step chopped in situ, lambda sculpting and cracking technique. So all these techniques, they work very well in a simple posterior polar cataract. Simple posterior polar cataract means where the posterior capsule is intact. It is fragile, weak and brittle. It's adjacent to the posterior capsule but not defective. No extension of the anomaly into the nuclear complex, and there is a preventable posterior capsular disruption. But what about the treacherous complex posterior polar cataract with posterior capsular anomaly? It means there is the posterior capsule is firmly fused with the cataractous plaque. There is a pre-existing capsular defect or hole. There could be segmental or complete agenesis of the posterior capsule. There could be anomaly which is extending into the epinuclear complex. And in no way in all these cases you can prevent the posterior capsular disruption. Posterior capsular disruption has to take place in all these cases. So the purpose of the study is to describe efficacy of a new surgical approach, high dissect, in the management of complex posterior polar cataract, and minimizing the further disruption of the posterior capsule and prevent the posterior segment complications, and in preventing pre-extraction posterior capsular disruption. We took 22 cases of posterior polar cataract from our center in Delhi. On the basis of clinical examination, these cases were grouped into two simple and complex posterior polar cataract. We took up all the complex posterior polar cataract into our study. Preoperative evaluation was completed with biomicroscopy, anterior segment OCT, and specular microscopic examination, fundus photography, FFA, and the posterior segment OCT. The surgical approach in all the cases, in all the 10 cases, was taken place with the high dissect technique. High dissect means it's a bimanual irrigation and aspiration cannula controlled dissection, separation, and extraction of the cortical matter, epinuclear membrane, and polar cataractous plaque with simultaneous posterior capsular axis and without using the phaco probe. So this is the technique I'm going to show you here in this video. So we need to do a good capsular axis. The capsular axis has to be a little smaller than what we normally plan for the normal cataract. You should avoid cortical cleaving hydrodissection. I'm doing here multi-segment hydrodissection, means you are injecting very small fluid all around, and then using a low phaco forces, low energy, and low stress on the posterior capsule, you are segmenting the nucleus into 2 segments. And this nucleus, after segmentation, is emulsified with a very slow process without any haste. And then using the bimanual technique. Now you can see here, because I am using the irrigation and aspiration cannula and aspirating the cortical material first without disturbing the center plaque. Now this is called as the segmental technique, like you are taking out the cortex and segmenting it away from the center 3 millimeter. So this is how you can see now, this is the plaque which I have left finally to support the posterior capsule. And then finally I am going to take out this plaque slowly, and you can see the plaque is now being taken out with the help of the aspiration cannula. You have to be very slow and controlled, and at the same time I'm putting the traction on the posterior capsule, like trying to separate this plaque from the posterior capsule and tearing the posterior capsule slowly with the help of the aspiration cannula. So you can see very slowly I'm trying to remove all the plaque and removing it from the posterior capsule slowly. And then finally what you can see is there is a posterior capsular rhexis which has happened along with the removal of the plaque. Now this is followed by the completion of the remaining cortical and epinuclear material which is there in the sub-incision area. And once you complete, your surgery is complete, you protect the posterior segment complication. So in 17 cases, the complex posterior polar cataract were 45% in our study. Most of the cases were between 20 to 40 years of age. This was their data. And what we have seen is in all out of the 10 cases, the 9 cases where we could make a successful PCC. The vitrectomy was required only in 1 case. In the bag IOL was put in all the cases except one case.
Sir. Please conclude.
The vision was removed, and to conclude, the high dissect bimanual low vacuum controlled aspiration of the cataractous plaque while creating a controlled posterior capsular axis is the most suitable surgical approach in the management of complex posterior polar cataract. Thank you.
Thank you, sir. So next, yeah, you can start your presentation. Dr. Pradhi Todi.
Good afternoon.
Moon, you can come over here.
Faculty and all my colleagues, I am Dr. Paridhi, here to share with you our results of using the iris claw lens in pars plana vitrectomy following cataract surgery induced aphakia versus the scleral fixated lenses. I have no financial interests. The aim of a modern cataract surgery is to leave the patient with good pseudophakia. But sometimes things go south and we have to take an emergency exit of implanting special methods of IOLs in insufficient capsular support. In this regard, iris claw lenses have come up in a huge way, being a versatile player in both anterior chamber implantation as well as a retropupillary tuck. But we wondered how about using this along with pars plana vitrectomy with an associated lens or nucleus drop. So in our prospective interventional study, we enrolled 40 patients with post-cataract surgery aphakia, something very common and relevant in all training institutes. These patients, however, did not have any traumatic lens drops or IOL drops, as we found this to be a confounding factor in the outcomes of the final vision and complications noted. For the methods, we performed a thorough clinical examination of the anterior and posterior segment and recorded the BCVA, the best corrected vision, biometry, the central macular thickness, and IOP of all patients. After this, the patients are randomized to one of the surgical arms Both the arms underwent a 23-gauge pars plana vitrectomy, and phacofragmentation was done for removing the nucleus, or the IOL was removed from the sclerocorneal tunnel, made in all cases for either placement of a retropupillary iris claw or a sutured SF IOL. These patients were followed up for 12 months, and these were the outcomes measures that we did. The vision, both uncorrected and corrected, anterior chamber findings for hyphema, pigment dispersion, any lens tilts, IOP measurements, and the CMT measures. We found no significant difference in the pre-op BCVA, meaning the randomization was equal in both groups. In fact, the uncorrected and the final corrected visions of both the groups were statistically insignificant. However, the number of patients with better vision was numerically higher for the iris claw. Even with the complications, the most common complication for the iris claw group was pigment dispersion, leading to raised intraocular pressure in 2 groups, which was then controlled with topical medication, versus the scleral fixated group, which had more posterior segment complications of cystoid macular edema, epiretinal membrane, and 1 case of suture erosion that led to an IOL tilt. What I would like to highlight from my study today is that the vision in both groups were comparable right from the first postoperative day, and it was definitely better than aphakic refraction alone, encouraging us to plant a secondary IOL in selected patients. There was no rise of IOP in the long term due to any pigment dispersion, and even though literature reports choroidal and retinal detachments, we did not find any in our 40 patients, which we attribute to excluding trauma in our criteria for patient selection. With regards to pupillary dilatation, we found that it was adequate to allow us a complete fundus evaluation even with a retropupillary iris claw in the mid-periphery. So, having come so far, our next steps is to compare the time taken in both groups, to compare the refractive correction and astigmatism in both groups, as well as a gonioscopic grading for the assessment of pigment dispersion in maybe those which do not have anterior segment, visible pigment dispersion in the anterior segment. We also plan to audit to assess the impact of iris claw with PPV on the patient wait list for secondary IOLs. Thank you. Okay, so thank you.
Good afternoon, respected judges and all dear delegates. So today,
timer start कीजिए please.
So today I'm going to present a case on a study that we did in our department on the analysis of cases of different grades and types of posterior capsular opacification and correlation with pseudophakic cystoid macular edema and the choice of performing NDA capsulotomy on the basis of visual outcome. So there have been no financial support and sponsorship for this study. So as we all know, posterior capsular opacification is the most common post-operative complication of cataract extraction, and pseudophakic cystoid macular edema has also been a very common complication following both complicated and uncomplicated cataract surgery, which becomes apparent about 6 weeks following surgery. And NDA laser capsulotomy has really helped in treating the posterior capsular opacification. So the objectives of our study were to evaluate the incidence of different grades and types of posterior capsular opacification following cataract surgery, and to see whether pseudophakic cystoid macular edema was present with or without PCO in reducing the visual acuity post-operatively, and to take a decision on NDA capsulotomy for improving the visual acuity. So we did a very comprehensive ophthalmic examination for the patients, including to see the cystoid macular edema post-surgery by OCT-FMT. And those who developed PCO were also graded and seen, and then we had to take a decision on the NDA capsulotomy. And the patients were followed up every 2 weeks, 1 month, and 3 months. So for the inclusion criteria, we included patients with cataracts like traumatic and senile who underwent small incision cataract surgery and phacoemulsification in a 1-year period from January 2021 to July 2022, A total of 50 cases were enrolled, and we looked for posterior capsular opacification within 6 weeks to 1 year of the surgery, and macular edema if it has developed within 6 weeks to 12 weeks. We ruled out any other coexisting causes of macular edema. And those who had coexisting PCO and macular edema also within that period of 1 year. So we did not, in the exclusion criteria, we did not enroll cases who already had pre-existing cystoid macular edema due to any other causes like diabetes, hypertension, uveitis, complicated cataract surgery, etc. And also who developed PCO later after 1 year of surgery. So in the results of the study included that the maximum number of PCO cases were of Sommering's ring type, followed by Elschnig pearls and fibrous type, and maximum people with poor visual acuity belonged to the fibrous and Elschnig pearl type. When we did the grading of the PCO, grade 3 and 4 were more common, and with classic Elschnig pearls and very thick homogeneous layers. We also found 2 cases of pseudophakic macular edema in the cases. Those who had coexisting CME with PCO, such patients, 4 cases we have found in our study. And after NDI capsulotomy, the vision had improved in almost 42% cases. So these were some of the cases on which the NDI capsulotomy was done. So this was also a case of PCO, which was after 7 months post-op, on which we did NDI capsulotomy at 7 months and then followed up at 8 months. And this was a case of pseudophakic macular edema, which was seen in a patient post-uneventful SICS at 2 months. So many studies have been done on this topic as of yet. The BCVA has been calculated to be maximum patients have developed 6/12 vision and better, but 24% had 6/18 vision. So many studies that have already been done has showed us that the average time interval between cataract surgery and NDI laser capsulotomy was almost 23 months. And it needs highest pulse energy in NDI capsulotomy for the fibrous type of PCO. And eyes with traumatic cataract are more likely to develop PCO. So in conclusion, mainly the BCVA of the patients that have been calculated are 6/12 or better in 76% cases, while 24% recovered to 6/18. Pseudophakic cystoid macular edema was seen in 2 patients, and coexisting both CME and PCO was found in 4 patients for whom we withheld the NDI capsulotomy and continued with anti-inflammatory eye drops and frequent steroid eye drops. So in 2 cases of fibrous PCO, NDI was tried but in vain. So these were my references. Thank you.
Thank you, doctor. We are not asking any questions. Thank you for being present over here. Because of the lack of time, we conclude this session over here. Thank you.